Okay, I think it's time to start the webinar, and I want to thank the organizers and of course the presenters for joining us here and at this Tuesday afternoon. And we're going to discuss the brachial plexus lesions in babies, and the main theme that is that a brachial plexus lesion in a baby is not simply a lesion in a small brachial plexus. And I have found these beautiful presenters that you see here to share their view on a brachial plexus birth injury. I will start off with the introduction. I have no disclosures. And the take-home message of this webinar will be that the brachial plexus lesion in babies is not simply a lesion in a small brachial plexus, but that it has unique features compared to traumatic adult brachial plexus lesion, and that you have to treat these patients accordingly. So the key differences of brachial plexus birth injury, that the trauma mechanism is different, that the regenerative capacity in infants is different, that they have an improved brain plasticity, but also that neurological evaluation is more difficult simply because these children will not perform a motor task when you ask them to. They have developing and growing limbs and joints that you have to deal with, and of course, anxious parents. So this will be the program. I will give a short introduction. Then Howard Clark from Toronto will share his indications for nerve reconstruction and its neurosurgical technique. Linda Yang will discuss the added value of MRI and EMG. Mariano Sokolowski will present his view on brain plasticity. Unfortunately, Raymond Say is not able to join the webinar, but he sent us his pre-recorded presentation, and Tom Quick will present the London experience. And afterwards, we will have a summary and discussion. I also asked all the speakers to present a surgical pearl for you to remember. So let's start off with the introduction. So to give a short presentation about our setting, we operate from the Leiden Nerve Center, and we see it's a tertiary referral center for nerve lesions in the Netherlands. We perform around 20 brachial plexus birth injury surgeries, primary surgeries per year, and from 1990 we have treated around 500 babies with nerve surgery and over 250, maybe 350 children with secondary surgery. And we think that treatment of brachial plexus birth injury is a teamwork, and that's why we host a weekly multidisciplinary outpatient nerve clinic. We as neurosurgeons see these patients at the timing of the nerve injury, and later on we are joined, of course, by the orthopedic surgeons, the rehabilitation specialist, our pediatric physiotherapist, occupational therapist, and of course a clinical neurophysiologist. So the trauma mechanism in these babies is different. In adult traumatic nerve injury, you have a high velocity, short duration injury, and this will provide true ruptures. So Sunderland grade 5 lesions, complete discontinuity of the nerves. And in addition, you will have root avulsions. In birth brachial plexus injuries, the velocity is low, but the duration is longer. And here you see a graph of the delivery time and the forces. So you see that these forces will end up over 10 to 15 seconds. And this will typically result in a Sunderland grade 3 lesion. So there is a neuroma in continuity. But also this trauma mechanism will provide root avulsions. And we found in a series of CT myelography that in simple C5, C6 lesions, 40% of children will have a total or partial root avulsion. The nerve lesion in younger animals has been studied by Fullerton, and they compared adult sheep with newborn lambs, and they performed a surgical repair of the C6 root. And afterwards they did electrophysiology, and they found that the sheep, compared to the lamb, that the lamb had a much higher velocity, conduction velocity. And this probably means that the generation of larger fibers in lambs is better than in adult sheep. So it was concluded that these younger animals have a greater potential to regenerate neural pathways. As said, the neuroma in continuity, I call it the signature dish of brachial plexus birth injury. So there's no complete discontinuity. And here you see an example during surgery, and you are viewing from the top. So this is medial, this is lateral, cranial, and caudal. So this is your C5 root, C6, C7, and here you see your distal stumps, and all in between is a large neuroma. And because there is no complete discontinuity, there will be always some signals on the EMG. So at the age of 3 to 4 months, it's often considered too optimistic for indication. And you also see some continued but very slow clinical improvement, which makes it very difficult how to select patients for surgery. And also the intraoperative decision-making may be difficult. In our hands, intraoperative CMAPs did not prove useful. And especially the decision to cut or not to cut may be a very difficult one. So the surgical pearl that I want to present is with the sensation. Because when you consider these nerves as the electric cables, then the brain is the programming unit. And of course, this programming unit needs input and it provides output. This input is sensation, and you will need sensation and motor output to control hand movements. And this is something we recently published. So we examined a group of 50 patients, and we examined sensibility with Siemens-Weinstein filaments. And when there is a marked decrease in sensibility, so they feel the bigger Siemens-Weinstein filament, you see that their hand function decreases. This is in children with a C5, C6 lesion, in which hand function is considered to be normal. So the surgical pull I want to present is that sometimes when you have a root avulsion, you can see a small ball, which will be your dorsal root ganglion. And this means that you can say that these are the posterior root filaments and these are the anterior root filaments. You have to, of course, resect the dorsal root ganglion, and this means that you can selectively target the motor part of the nerve and the sensory part of the nerve. And this is how it looked like during surgery. So this is your avulsed root. This is your dorsal root ganglion, which has been partially resected, and the ventral rootlet is relatively small. And what we sometimes do is that we connect the supraclavicular nerves from C4, we connect them to the posterior part of your roots to provide extra sensory fibers to the brachial plexus. So this was my surgical pearl to start off, and I would like to switch to Howard Clark, who will be presenting his indications for nerve reconstruction and nerve surgical technique. Howard, thank you.
Thank you very much, Willem. It's great to be able to join you and talk about this. This is one of my favorite topics, as you probably know. I would love to be able to say, after 30 years of studying this carefully, that I had a really simple answer to the question of who should have an operation. And I hope I will take you to something that is fairly straightforward and fairly easy to understand, but it isn't a one-time, one-fits-all solution to this question. So we all know what these babies are like. We all know what they look like when we examine them. And when I started doing this 30 years ago, we had a very simple way of deciding who should have an operation. So a primary nerve operation was for patients whose biceps had not recovered by the third month. And this was very straightforward, very easy to follow, very clear advice. But in our hands, we had problems with this. When we examined patients early on in our series and looked to see how they were doing and looked at patients who had good recovery at 1 or 2 years versus those who had poor recovery, this is using an old scale, but we found that patients with 0 elbow flexion at 3 months of age, some of them actually went on to good recovery as well as the ones with poor. And in fact, there were patients like the one I've shown you in red at the 0.6 who have elbow flexion present, but still go on to poor recovery. So it didn't assort these patients as well as we would have liked. So we did a significant amount of work doing a statistical analysis and found that really adding other things other than elbow flexion to this mix gave us a far better prediction of outcome and the need for surgery. So we added elbow, wrist, finger, and thumb extension to our technique for assessing these patients, particularly at 3 months of age. And we had a different assortment where all the patients now having what we call the test score, all the ones at less than 3.5 did badly. So you can offer all of them an operation. But the ones with higher scores, actually, some of those patients did badly as well. And this was really the key for us, is that getting past that elbow flexion at 3 months of age doesn't necessarily mean that an operation won't be a good thing. There may be patients who still would benefit from nerve surgery. And in fact, when we went back some decades later and looked at a larger sample of our own patients, we found that in our experience, a lot of them fell into that standard binary dichotomous definition of elbow flexion or not. We had 158 patients who had elbow flexion and they all went on to be fine. We had 29 patients who had no elbow flexion. We operated on them. We were happy with those results. But the key thing here are the outliers. Less importantly, the 6 patients who did have elbow flexion and we didn't need to operate on. But more importantly, there were those 16 patients who had elbow flexion at 3 months of age. By that standard criterion would not have a nerve operation, but we actually needed to operate on them to get the best possible result for them. So not surprisingly, with such a heterogeneous group of patients, we need to have a way of sorting out individually what will work for any patient. So we see these patients frequently. We assess them every 3 months from the newborn period. We use our AMS scale. Linda's going to talk about this more, but we don't do electrophysiology. And we look at the patient and look for really bad things. So these are things that all of us will spot. This is a patient with a T1 avulsion. He has clawing of the hand. The intrinsics are not working. This patient is about 6 or 9 months old, way past when the surgery should have been done. But this illustrates what we know is that when the hand is completely frail and there is no mobility in any of the movements in the hand at the time of birth, that's an absolute indication for a nerve operation, which we would typically recommend doing at about 8 weeks of age. So you operate at 8 weeks of age, which gives some time for the occasional patient with a T1 neurapraxia to recover and show some of this function, so you don't take out a T1 that's getting better. We also know that Horner's syndrome with meiosis and ptosis is an absolute indication for early nerve surgery, and that's well demonstrated. So those are 2 really clear indications for bad patients that need early nerve surgery. Then we have a whole bunch of patients in the middle ground. They don't have these extreme lesions. They may actually have upper trunk lesions or upper and middle trunk lesions. They may do well at 3 months of age, but do they finally get to the place we want them to be? By 9 months of age in our hands, they should be able to, against gravity, get the hand all the way up to the mouth in this primary position with the elbow at the side and get this cookie into the mouth. And that's a good final outcome at 9 months of age after spontaneous recovery. If that doesn't happen, even if they have anti-gravity elbow flexion, even if that anti-gravity elbow flexion is more than half range, if the cookie does not get to the mouth, that predicts that their final outcome will also be poor, and we can operate on those patients who have lesser injuries at a later age. So the severity of the injury is inversely proportional to the age at operation. So that gives us these broad guidelines for primary nerve surgery in these patients. Horner syndrome and clinical evidence of T1 avulsion, both absolute indications for an operation. Our test score, if it's less than 3.5, also an indication for surgery. And we have this test, the cookie test, which we do at 9 months of age, looking to see if their final outcome is where we want it to be. So if I put this all into an algorithm, and if you ignore the grayed out bits on this chart for a minute, you have two columns. The column on the left are the most severe patients, the ones we all know need an operation, the ones with avulsion, T1 out, Horner's, both. Those patients need an operation, and nobody's arguing about those. In the middle column, we can follow the patients who have some function, don't have evidence of T1 out, don't have a Horner's. So we will follow them along and do a test score at 3 months of age, which will pick out the ones that aren't quite as bad as the worst of them, but are clearly worse than the middle range patients. Those patients with the failed test score will get an operation at that point. Our next testing point is at 9 months of age when we do the cookie test, but you'll see we've added another box in between to follow along the patients who have limited function at 3 months of age, but pass that test score. So if they have grade 2 or grade 3 elbow flexion, they may pass the test score at 3 months of age, but we just wonder, will they actually get along to pass the cookie test at 9 months? We will see those patients at 6 months of age. And if there's no improvement at all, we may offer an operation at that point. If they're still at AMS grade 2 or 3 elbow flexion at 6 months of age, the probability they're going to pass the cookie test is low. And then, as I've already said, that 9 months of age is the exit test, if you like. You have to have good spontaneous recovery by 9 months of age and pass the cookie test to avoid an operation altogether. So we have the best patients of all have full function by 1 month of age. They have no sequelae. That's fantastic. We have the worst patients with the Horner's and T1 out. They have the worst prognosis. They get an operation straight away, but we have everything in between. And what we're doing, following this middle column in this algorithm, is following along and trying to sort them out where along that wide spectrum they end up. Now, what's new for us in the last 5 years is that just assessing motor function may not be sufficient to help parse these patients out. And it's become increasingly evident to us that sometimes biomechanics around the shoulder can mask nerve recovery. And this became evident to us when we sent a patient off for a CT myelogram in anticipation of doing a full-on plexus reconstruction. Coincidentally, they got both shoulders in the images of the myelogram and showed that one shoulder was almost totally subluxed out behind the glenohumeral joint. So there was significant subluxation in the one shoulder. Because I never really like having an orthopedic kind of operation done shortly after nerve surgery, I sent this kid off to my orthopedic buddies and we discussed it and did the shoulder operation first for that patient. And we didn't expect this, but when we saw that patient about 6 weeks after the operation with the shoulder now in a reduced position, the elbow flexion was actually fantastic. The patient passed the cookie test. We no longer had any indications to do a nerve operation, and that patient has never gone on to nerve surgery. So there may be a small group of patients, highly selected patients, in whom that shoulder pathology may mask good nerve recovery. So we address the shoulder now and we follow the shoulder separately from the initial visit. In the patients who have early evidence of shoulder pathology, we may put them into a super splint. This was developed by Cindy Vercher in Vancouver. It's a splint which holds the upper extremity in external rotation of the shoulder and supination at the forearm. Our indications to do this are infants at between 4 and 8 weeks of age who have limited active external rotation of the shoulder, so they score AMS less than 2, or those who have any diminution in the passive external range of motion at the shoulder. So we put these kids into super splints for nights and naps and follow them along. And we certainly have the impression, I can't prove it, that we've rescued some of these patients from lesser pathology, so that as we get reinnervation of the extremity, it's happening with the glenohumeral joint in a better position and in a freer, more mobile position. The other way we have of assessing the shoulder, aside from clinical examination, which is actually surprisingly straightforward in newborns, is to assess them with ultrasounds, looking for something called the alpha angle at the shoulder, which is analogous to the alpha angle at the hip for dislocated hips. So these ultrasounds are taken from the back. The skin is at the top of the image. The chest is, in fact, at the middle of the image. And you can see on the left image, the humeral head, you can see the scapula. On the right image, the annotations are added. The one line goes along the posterior scapular spine. The other line is tangential to the posterior lip of the glenoid and the humeral head. And that produces an angle called the alpha angle, which here is 28 degrees on the normal side. On the abnormal side, you notice two things that are distinctly different. The ossific nucleus of the humeral head is posterior to the scapular line, and more than half the humeral head is posterior on internal rotation. And here the alpha angle is 49 degrees. So this is a significantly subluxed shoulder joint in this patient at this time, and we will consider doing something about that directly. I don't have definitive data. I don't have long-term follow-up. I don't have hard answers for this, but we have looked at our early experience in 15 patients for whom we undertook primary surgery of the shoulder, not the nerves, in the first year of life, because either the shoulder was apparently coming out on either clinical examination or ultrasound examination at an early number of months, or where we felt the cookie test was failed simply because the shoulder was held in such tight internal rotation. Try to flex the elbow and the forearm bangs against the chest wall and simply can't get into a better position. In those selected patients, 13 of those patients went on to pass the cookie test or score 7 out of 7 for their elbow flexion at the last follow-up. So they were all rescued from a full-on nerve operation. One, granted, had a nerve transfer as an isolated procedure to augment elbow flexion. The other two we've lost for follow-up. So this is early data. It's not definitive, but it suggests there may be a role for this. And that gives us these soft indications. These indications I've grayed out because we haven't defined these fully and thoroughly yet at this point, but these soft indications to consider surgery of the shoulder as the first effort. So a failure of the supersplint, clinical evidence of shoulder subluxation that persists after treatment, an alpha angle greater than 30 degrees, or as I've described, when they get to the cookie test, if the forearm is banging against the chest, then that may be relieved in some cases by a shoulder procedure. So that gives me to this full-on algorithm, which I fully admit is not simple, but it adds the column on your left where we look for a shoulder that's at risk, a shoulder that may be coming out of position early on at 6 weeks of age, to put them into a super splint, if that's appropriate. We evaluate the shoulders at 6 months and 9 months, and if the shoulder appears to be subluxed significantly, we may recommend shoulder surgery as the first step and then send them back into the algorithm for possible nerve surgery to follow that. So you can still in your brain simplify this into 3 separate columns. On the far right, the terrible lesions need an operation, no discussion. On the far left, watch for shoulder pathology and follow that along at the same time you're watching for nerve recovery. And in the middle, watch nerve recovery as it progresses over time to sort out all those countless patients that are somewhere between the extremes of really good and really bad. So I've been asked to talk about nerve surgery as well, and I can actually make this one I can make simple. So when we operate on the nerves in the neck and we're trying to reconstruct the brachial plexus, we see this image, which is very much like Willem's image, a big neuroma, particularly here in the upper and middle trunks. What do we do with this in this surgical situation? Well, my answer to this is really straightforward. You cut out everything except nerve, which shows a normal fascicular pattern on external examination. You can see the fascicles through the epineurium, through the perineurium, and which when you stimulate it, produces the appropriate muscle response. So it has to look normal and has to work normally. And that's all that should be left behind at the end of the plexus resection. Everything else can go. All of the neuroma can go. Everything else can go. Now, there's one little exception here because we sometimes have patients who may have C6 and 7 avulse. They may have a C5 root available. They may have an incontinuity avulsion of C8, and T1's intact. So we have one root intact and only a C5 root to graft from. In those patients, we may leave that C8 in continuity avulsion alone because we don't have enough stuff to reconstruct it just from C5. We may leave that in continuity, reconstruct everything else from C5, simply because there may be a few fibers that have traversed that avulsion at C8 that we could leave behind. So that's the exception to this rule, and every good rule needs an exception. My little minor surgical pleas are don't make big, long incisions along the leg. We can get the sural nerve out even without an endoscope using 3 incisions on the leg, which are much better from an aesthetic point of view. Use Tisseel. You only need Tisseel to put these together. You can drop it in step by step to get excellent coaptations at any of these ends. You can put the nerve grafts where you want them and produce a beautiful brachial plexus without any surgery, without any sutures at all. So here is my surgical pearl for you, which is to resect everything except nerve, which both looks normal and stimulates normally. Neurolysis is only used to discover one of these normal looking nerves that's encased in scar, but where there's a plane between the scar and the normal looking nerve. So thank you very much for the chance to talk to you. I'd be delighted to have any questions if you have any.
Thank you, Howard, for sharing your huge expertise and experience with these lesions with us. And Linda, you raised your hand, please.
No,
you
I
didn't raise
didn't.
your. Oh, you raised your
No,
hand.
no, I'm sorry, I didn't. But there is something in the chat box.
Right, there's a question from Martijn. Martijn Malesi asking you, Howard, why would you not at first do excessive physiotherapy and second Botox instead of surgery, or instead of shoulder surgery?
Well, we have actually very good data for that. Sorry, I'm not muted. Good. So we have really good data for that. We've studied the patients in whom we used Botox and therapy to try to ameliorate the shoulder. And we had a large group of patients where we also used it in the triceps to try and encourage better elbow flexion when both seemed to be working and the triceps was overwhelming the biceps. And that data for us clearly showed that when we put Botox in the triceps with 1 or 2 doses over a number of months, we can actually produce a permanent effect, a lasting effect, where we had some improved elbow flexion over time. When we looked at a large cohort of patients where we'd injected Botox into the internal rotators of the shoulder and added splinting or stretching or whatever else to all of that, they all had a temporary effect, which was measurable and demonstrable, but it always wore off. It never produced in any of those patients a lasting improvement in shoulder function. So we still use Botox in the internal rotators to buy time. We sometimes have to wait to get an operation done, or we want to see how the patient will do with less powerful internal rotation, but we've never succeeded in permanently treating the shoulder imbalance with Botox alone.
Because that's very interesting, because the new step in your algorithm is the super splint. And why do you think this works better than physiotherapy or Botox? Because it might also have a temporary effect. What's your opinion? How does it work? Very good.
I think it is a very temporary effect for 2 reasons. 1, the patients don't tolerate for more than 5 or 6 months if you're lucky. But 2, what you're doing with the super splint is quite different. You're trying to hold the glenohumeral joint in a good position to have good growth of the morphology of the joint while the external rotators are coming back. So it's not used in patients we would do Botox in. It's not used in patients. Very few of those patients then go on to shoulder surgery. Those patients either just simply get better with the super splint alone, and in a small number, we've taken them on to nerve surgery, but it's not a replacement for shoulder surgery. It is a temporizing thing used in those very early weeks of life, from about 6 weeks to maybe 8 months if you're lucky. It's for a different subgroup of patients. I'm afraid to say, as I keep suggesting, there are many, many variations in this puzzle which have to be individually managed.
Yes, and you've assessed a lot of these puzzles or pieces of the puzzle by yourself and by your outstanding scientific work. There's one question, because in your treatment algorithm, these patients are getting older all along. Do you have the impression that if you perform surgery at a later age, let's say 9 months, provides you different results than surgery at 2 or 3 months of age? Do you have any comments on that?
Absolutely. So the one thing that matters critically is nerve surgery for a T1 avulsion, for a T1 lesion. So it's become clear to me that that should be done as soon as possible. And that's why I'm operating on those patients at 8 weeks of age. So when you do a T1 reconstruction at 6 months or 9 months, you do not get the results you want. You do not get the best of the results in those patients. When you operate on a patient with an upper trunk lesion alone or an upper and middle trunk lesion at 9 months, I don't see a difference between those results and similar patients operated on 6 months. Now, those patients aren't operated in my hands at 3 months of age because they pass the test score, they don't have a Horner's, and they don't have T1 out. So they're getting an operation in my hands at 6 or 9 months, and I certainly don't see the difference between those two groups of patients.
Okay, thank you so much.
And there's another question from the audience to Howard. Shall we go on with that? It's from Pamela Highland. She's asking, would your approach be different for a bilateral lesion? Would you do earlier surgery?
The good news is that the bilateral lesions are relatively uncommon. And the other bit of good news is usually they're very asymmetric. And usually one of the lesions is very mild and the other is the more severe one. So it is happily, at least in my experience, rare that you have to operate on both sides. So you follow those patients along and monitor the worst side as the potential candidate for an early operation. And usually you get lucky. The only patient I've operated on both sides in the same patient was a breech delivery, which we don't have many of here in Canada. And he did have bilateral C5-6 avulsion. So that was a very difficult situation, but that's rare in my experience.
I think I can agree with you on that there's usual asymmetry in these bilateral lesions. And talking about breech deliveries, because we see that the number of breech deliveries is decreasing very much. How did it affect your clinical situation, your practice?
So we see very, very few breech deliveries because it's really become, in Canada at least, almost all of those patients go on to a C-section, or those pregnancies go on to C-section. So it's pretty uncommon for us. So we happily don't have to deal with that very often.
Okay, thank you very much. I don't see any questions left on the chat box, and I think it's time also to move on. And I will pass the word to Linda Yang. She is from Ann Arbor, and she's also very critical in every step of the way, from selection to nerve surgical procedures, critical about every step. So Linda, please share your thoughts with us.
Thanks, Willem, very much. So in the next 15 minutes or so, I want to follow up on your theme of how babies are different than adults, and also attempt my best to complement Howard Clark's talk as he has given it there in terms of indications in surgery. So the question that Willem asked me to talk about was, do ancillary studies have a value in the treatment for NBPP? There's no real right answer yet. We're looking into it, but I hope I give you some evidence in the next few slides so that you can make up your own mind in a way. So let's see, I gotta advance, okay. I have no financial disclosures, the typical American need for doing so. Okay. And then special thanks to a few people that I work with, Hemant Parmar, Brandon Smith, Kate Chang, Kathy Spires. But in addition to these, unlisted are basically everybody on this, from Martin to Howard to Willem to, Mike Fox and Marco, and more recently Tom Quick. So all of you have had some influence on why I'm asking the questions that I've asked in this presentation. So again, as an introduction, why should we operate? Because they're not little adults, because they are more plastic, as Howard mentioned, or as Willem mentioned, and as Howard mentioned, we can potentially beat the natural history of NBPP. So when should we operate? I think Dr. Clark already covered this in great part, but I needed to put this in context of ancillary studies. So let me just do that. Some of this is historical. Dr. Clark mentioned Gilbert's indications, and these are some older algorithms for indications that do not include ancillary studies. So there's Peter Waters' lack of biceps function at 5 months of age, and there's Bertelli's failure of Tyrrell test at 6 months of age. As published, and as I've heard them speak, none of these involve any kind of ancillary studies in terms of electrodiagnostics. So Dr. Clark has the more updated version of this, but at last publication listed below, as he mentioned, he does not use electrodiagnostic studies. So then there are others. So Dr. Malesi, when I was working or fellowing with him, basically enticed me into looking at this from the Ann Arbor side as well. And what he came up with was that 10 dichotomous items concerning active clinical joint movements, et cetera, were gathered at 1 week. And needle electromyography of the deltoid biceps, triceps muscle were gathered at 1 week, 1 month, and 3 months of age. And of course, Willem is on this as well. So then Mario Siqueira in South America includes ancillary studies, maybe. So what he says is, amongst our patients, surgical treatment was indicated when palsies persisted for at least 4 to 6 months in upper lesions and 3 months in total lesions. Neurophysiological studies and MRI scans were performed routinely at the beginning of the series, but maybe not so much towards the end of the series. So indications and timing remain varied, but just like Howard was talking about, most considered absent hand function or flail arm, avulsion at T1 with Horner syndrome to be an absolute indication for intervention. We say 3 months of age, which is essentially 12 weeks. Howard says 8 weeks, but I think we all agree on this. So a few years ago, what did we do? So this is what we ended up doing. And you see, we do include some of this, but we didn't know what the value was. So that's what the next part of all of this. So what evidence actually supports these ancillary studies for indications to operate, or what nerve reconstruction strategy to use? So the first thing to think about is the EMGs have a lot of problems. When I was with Ralph Birch and Sheila Smith, these EMGs in babies are very different than EMGs in adults. And so, first of all, the diagnostic interpretation is really subjective. What's the inter-rater reliability? Unlike adults, EMG may identify the lesion, but really doesn't prognosticate. And why is that? Is there some question of luxury innervations and how many motor units are enough to actually confer function? Because as Howard mentioned, a lot of times you always see some things and it doesn't help you. So the first thing we were looking at is inter-rater reliability. And we find that for reasons that have already been discussed, C5 is very difficult. You don't get a lot of good inter-rater reliability for electrodiagnostic to assess the C5 root. Some of the roots like C7 are very good, and the rest of them, I think we were being generous when we said substantial agreement, but not so good. So why do we think there is this, over optimism? Well, there are often seen MUAPs in clinically paralyzed muscles. So this is that, well, you stimulate them or you do something with the nerve, and they move, but the baby doesn't know how to move it and doesn't move it, which I agree with Dr. Clark on this. If you're going to operate on this kid, it is resect the neuroma or, do something like a nerve transfer that basically addresses that. Paralysis, but sufficient MUAPs, what's sufficient? Nobody really knows. Then this luxury innervation was somewhat explored very early on, and by Zallis in 1965, followed up by, you notice these names here, Willem and Martin, over in 2001. So that still leaves you to, why do we overestimate? Why do we overprognosticate, or why are we over optimistic that these kids are going to recover? So a few things have been put forth that aren't the same as in adults, which is maybe there's an overestimation due to small muscle fibers. Maybe there's persistent fetal innervation. Maybe there's developmental apraxia. Maybe there's synkinesis. Don't know, but the utility of EMG is still yet controversial. So I'm still going after at this point, like, how do we need it at all? So is electrodiagnostics or MRI better for detecting pre versus post-ganglionic lesions? So we looked at some of this and we said, okay, so we compared the accuracies of electrodiagnostics to imaging and came up with an overall accuracy of 74% for electrodiagnostics, and for imaging, 69% at the time that we did this several years ago before advanced imaging. So it's particularly good, however, if you look at the specificity of the lower roots. So what that led us to say is really the indications and timing still are varied, but I repeat again, the lack of hand function and T1 avulsion and Horner syndrome is an absolute indication. But aside from that, I'm sort of tending towards Howard here, which is electrodiagnostics might provide some assurance to meet indications for early surgery, particularly at the lower nerve roots, but you have other ways of doing that. And I don't particularly know, aside from that, what else you might get from electrodiagnostics after collecting and looking at this for, over 10, 15 years at this point. So what about imaging, right? Okay, have we gotten better at imaging? I think we have. For those cases where you're considering grafting, having nerve root donors and their integrity is very important. I'm not going to get into the debate of nerve grafting versus nerve transfers versus the use of both. But really, we are still interested in nerve root integrity. And maybe in those cases of pan-plexus lesions, you want to know every donor that's possible. And we may be losing some if we don't look carefully. So we started looking at imaging and we say, sorry, did I go backwards? Apologies. Oh, shoot. Okay. So refinement of high resolution imaging techniques allows for determination of nerve root integrity. And we published that a few years ago. But what about nerve rootlet integrity? So CT myelography is used in preoperative assessment, as you've already heard. But we think there are some disadvantages to CT myelography, which is it's an invasive lumbar puncture, it's installation of iodinated contrast, it's ionizing radiation and indirect visualization of the nerve roots. And on the right side is an example of a CT. Having said that, it does give you some information. We certainly started out doing that until parents started protesting and their primary care physicians or pediatricians were telling them you shouldn't get a CT at that young an age, et cetera. So we started to go towards MRI, and I fortunately had a good radiologist that was also interested in the subject. And so MRI is the opposite. It doesn't require all of these, and the parents are much happier as well. So we had that previous study that established the accuracy of MRI imaging, but to date, no studies had evaluated the ability of high resolution MRI to evaluate nerve rootlets. So we did a IRB approved study of 60 infants with diagnosed neonatal plexus. We looked at all of their nerve roots on the normal side and on the abnormal side. And all imaging studies were reviewed by 2 board certified pediatric neuroradiologists. And basically, for those that are interested in the technique, I have listed it right below. So what kind of pictures do we get? We get pictures that are as good as this, which, you oftentimes you say, well, you just put forth your best picture, but many of, if not all of our images look like this. You can really see the dorsal and the ventral rootlets very, very well. So here's a movie, if I can get this to play, where you can take a look, and this is sagittal from right to left and then back. You can see the ventral rootlets, the dorsal rootlets, and you go around to the other side. Again, the ventral rootlets and the dorsal rootlets, and you can see that is all absolutely looking good. So then you can go with the coronal image to see the same thing. So you can see the rootlets coming off as well. And then you can see the other side of the rootlets coming in. And these pictures are really quite amazing and quite advanced for what I was experiencing before. So what about one that has a neonatal plexus? Well, you can see there's no root here. And you can see there's no root here. But you can see this little thing, which happens to be the denticulate ligament. Then you can also see it this way. With a sagittal, this is normal. You can count all the nerve rootlets. Right here, there's one missing and there's one missing. So here's another view of that same thing, missing nerve rootlets. So basically at this point, you know, instead of just continuing to show you pictures, we thought we'd put the data together. The first thing that makes it different than adults is, at least the adult studies that I know, and also theoretically, in adults, C8 and T1 are more likely avulsed than C5 and C6 because of the bony structure of the transverse foramen at the cervical spine. C7, T1 really doesn't have a very long bony foramen, whereas C5 and 6 do. Turns out that in this case, what we found was C7, and there is a bioengineer that is working on modeling of this, and basically says that the forces that are applied are probably more likely to avulse C7 because, again, babies are not adults. So it's, again, it debunks that babies are small adults thing. We also found out that rootlet avulsion definitely occurs in the absence of pseudomeningocele. For the longest time, we said that, well, the pseudomeningocele indicates rootlet avulsion. And in fact, with the CT myelograms, the early ones, that's what we were looking for, was pseudomeningocele to indicate avulsions. But in this, as we learn more, we're finding out that it can definitely happen. And then in almost half of the cases that you can have isolated or ventral or dorsal rootlet avulsions. And what that means, at least for those of us, or for those cases you want to graft, is you may be missing a root if you're just saying, oh, there's a pseudomeningocele, there's an avulsion, and so therefore we can't use that stump. So in the end, 99% of roots can be clearly visualized with high resolution MRI. Almost a third of the avulsed rootlets were dorsal only. And we're suggesting that this finding implies that nerve roots previously labeled as avulsed, but with only isolated dorsal root avulsions, may yet provide donor fascicles in reconstruction strategies. And of course, you know, if I know Dr. Clark, he's going to say, well, wait a second, where's your control, right? And of course, we're not doing laminectomies to look at all of these. So I don't have a gold standard control, but I do think that we're heading towards an amazing array of radiographic information if we just know how to use it and if we collaborate with our radiologists. So where are we going from here? Well, this one is very interesting, actually. I generally veer towards the 6 months to operate on stretch lesions in babies. But there was one particular one where our radiologist called me up and said, I see something really interesting in the extraforaminal plexus. I can follow axons now, and I can see that within this neuroma, there's an absolute disjunction of the axons here. I think you should go earlier. So when we actually went in there, it turns out he was absolutely right. Right here, there was almost like a cut in it where the two ends did not meet, even though the connective tissue on the outside really looked like it was just a stretched neuroma. So never had I really seen that before, and that's only in one case, but I think we're getting better. And in this one, I'm showing you also the suprascapular nerve you can follow out. And of course, that's the other side. So we're starting to go more and more into this a little bit, but let me just summarize because I think my time is up. And that is that electrodiagnostics has higher specificity than traditional MRI, maybe for identifying preganglionic lesions, especially at the lower roots, but not useful for prognosis. We think that maybe improvements in the resolution of MRI might take electrodiagnostics for determining the integrity of the rootlets and maybe even the extraforaminal plexus. And that's what this next thing is. And one thing I always like to say and end on is the goal of this surgery, you know, parents want their kid to be fixed and all of that. And I just don't ever say that. I say, I'm not trying to make your child completely normal. I'm just trying to get functionality. And as emphasized by our other speakers already, it's good to have an interdisciplinary team if you want to optimize outcomes. So again, I thank Willem and the organizers of the meeting. I thank all you that joined for your interest in this disorder. Last thing is the Pearl. I surveyed my trainees who are now out in practice themselves and asked them, what about what I have taught you during the year, was useful to you as you started your own practice, especially in terms of the supraclavicular approach or exposure. And these were the two things that seemed to come out. And that is surgical anatomy. In the case of a very badly injured or scarred BP, follow the ansa cervicalis back to C4, which then will lead you to the phrenic and the anterior scalene. And of course, Willem presented another reason for following the ANSA, which is, might be a donor for specific sensory transfers. And then in the case of avulsed or downward displaced BP, where you can't find anything like these massive, avulsion injuries, follow the omohyoid to the suprascapular notch, where you can find the suprascapular nerve, and then follow it back to plexus. I think that might be something I picked up from my time with Martin Malesi. So anyway, bottom line is, I hope you found this a little useful. I hope you can make up your own mind about the value of electrodiagnostics and imaging. And thanks again.
Thank you, Linda. That's a very good overview of EMG and MRI. Very interesting. Few questions come to mind. The first one is, you spoke that you often saw a pseudomeningeal, you saw no pseudomeningocele, but a root avulsion. Did you also see it the other way around? Because sometimes you can see maybe a pseudomeningocele, but with intact rootlets. Is that something?
Absolutely. We saw both sides. You're absolutely right. And we need to go back and count, because people ask me that, like, what's your count after looking at all those nerve rootlets? So I'll have that answer better for you in the future, but you're absolutely right. You see both ways.
Okay, thanks. Howard, you raised your hand?
Yes, so the question I have is, and this may be very specific to the technique used in different institutions, sometimes in our MRI evaluations, it's hard to count the bony levels. So we know there's avulsions, we know there's a pseudomeningocele, but we can't figure out which root it is. Have you had that experience at all? And how do you deal with it?
Yeah, not since we have been using this 3 Tesla. I mean, the count is actually, because the MRI is almost like a babygram, and we can actually follow each one down with the recons. So we're also very recently, which I haven't said before, 3D printing these babies, both plexuses, both sides. So that will also help to address your question as well, Howard, because then you have it in your hand and you can actually count them down.
Okay, interesting, thanks. And can you, because you brought forward that your current indication is around 5 to 6 months old, that you want to operate these children. Can you elaborate what is the timing of your MRIs?
We generally start to get a sense, and maybe Howard had some influence on this, at around 3 months. And so if we get a sense that the baby is behind the curve at 3 months, because of the wait time here at U of M to get these MRIs, we start signing them up for the MRI and the ultrasound, because we do the same thing to assess the shoulder, but we use an ultrasound instead. And so by the time that the study is scheduled and comes back and we discuss with the parents and we get the consent form and the pre-op and everything else, it's about 6 months or a little after, if we get the babies early. Then there are times when we just don't. And so there's some data from us and from others that, except in the case of the C8T1 avulsion, it doesn't seem like there's a significant difference whether you operate at 3 months or 12 months. And I think Mario has the same data that we do. Although if you really want to apply your statistics and milk it, you can see that there might be a trend towards better earlier, but I don't know that I believe that.
Okay, thank you. Any other questions? I think that I want to thank you very much again for your contribution. The next speaker has joined us, Mariano Sokolovsky. Mariano, nice that you are here. And he will present his view on brain plasticity, and he wrote a series of very interesting papers on this phenomenon, and we're very interested to hear your thoughts on it.
Hello, William. Thank you, honestly, for your invitation to participate here in this wonderful session. So I will try to share my screen. Please tell me if you can see it.
Absolutely.
Okay, perfect. So I will turn off the sound of my computer in order to not to annoy you with the volume of my videos, right? Okay, so we are peripheral nerve surgeons. So we fix cables, which are nerves, and that's our main task. But we should take into account that the cables go to a CPU, which is the brain. So taking into account the brain is an important task of any peripheral nerve surgeon, because there are some changes that occur at the CPA, which are called brain plasticity. So do not forget the brain. Brain plasticity, or neuroplasticity, better called, is the central nervous system's ability to reorganize and adapt to internal or external changes. It's an absolutely normal process in neural development. So, for instance, when you start riding a bike or learning to ride a bike, you do it under voluntary control, and then as the time passes, you start to move into automatic tasks. So, regarding plasticity, one important thing is that the younger, the better. So this is me when I was 17 years old, and that's me in a more recent picture with my family. And as you can see, things have changed outside my head, but also they have changed inside my head, and they will go on changing in the next future. And this is a future picture. So let's see this picture. You see, as age increases, the normal brain plasticity influenced by experience in the red line is decreasing. So the plasticity decreases with the age, and the physiological effort in the blue line required to enhance neural connections increases. So just to make a practice example, if my little children, Francisco is over there, wants to learn Swedish or Russian or Dutch or whatever language you want, it will be easier for him because he has more plasticity than me. So children are so plastic that they can even change the dominancy of the speech with an hemispheric lesion, for example, an OBBP on the right side, which affects the left hemisphere. So they can change it. That was demonstrated more than 10 years ago. So William posted a very interesting title for this webinar, which is a brachial plexus lesion in a baby. It's not simply a lesion in a small brachial plexus. And I absolutely agree with that in terms of brain plasticity. So we published, as William said, some review papers with Martin, but he was really the pioneer in this subject, for sure. Look at this article he published some years ago, where he studied what happened with the intercostal to the musculocutaneous nerve transfer. And I won't go very deep because it's all written, but you can see that there are some changes that occur after an intercostal to musculocutaneous nerve transfer. So before surgery, this is the state of the brain, and you know, there are some subcortical connections between different cortex, motor cortex zones and premotor cortex zones. So, for instance, if you're going to flex and raise a heavy weight, you will have to stabilize your thorax. So there is a connection between the thorax stabilizers, for example, the intercostals, and also the elbow flexion. So after this connection, after the surgery, this early phase, when the patient starts to recover, they move breathing, right? This is the so-called or all-called breathing arm. But after a while, with training, you get involuntary control without breathing. That's the late phase. And as you can see in the orange arrow at the right of your screen, there are changes that occur in the brain. So that's why we get voluntary control. But be careful, brain plasticity is a limited thing. The adult brain cannot create a new connection, it just uses an existing one. Donor and acceptor must have some connection between the two motor areas prior to nerve transfer, which are called horizontal intrinsic connections. So let's go, for example, to the hypoglossal to facial nerve transfer. There's a variation described by Sawamura, Stefano, Ferraresi, and Atlas. This is basically the surgery to cut the facial nerve and to put part of the hypoglossal into the facial nerve. And, there's a connection between those zones. So when you speak, you move your tongue. So there's a natural connection. That's why this is a very, very good in terms of success technique. So it gives very good results, as you can see here in the left, before surgery, on the right, after surgery. She's speaking, she's moving the mouth, she's also closing her eye, which was previously paralyzed. But what about the emotions, the spontaneous movement? They are connected not, of course, to the tongue, they are connected to the limbic system, which delivers the emotions. So if you're going to co-opt the hypoglossal to the facial nerve, you won't get a spontaneous smile. And this is a problem with this technique. And this is explained clearly with brain plasticity. In fact, with limitations of brain plasticity. So again, the message is brain plasticity is limited. The adult brain cannot create a new connection. So what about the hypoglossal again? Going to the musculocutaneous or to the biceps. Again, Martin and also Stefano published that this was not a very good technique, because even getting a good results in terms of strength, M3, M4, or whatever, there will not be a good voluntary control of this movement. So that's what the science says. Do not try to do this at home. I did this surgery more than 20 years ago, but as you can see, we use the hypoglossal nerve as donor, and when he moves the tongue, he's waving the tongue and the biceps is moving. It's awful, it's not a good result, so we abandoned completely this technique many, many years ago. And why? Because there is no spontaneous pre-existing connection between both hemispheres. So that's why probably it's difficult to get voluntary control. Again, the same message. One other way to prove our results is to measure the endurance or the fatigue after muscle reanimation. So we put a weight and we wait, right? And then we see what's going on. We published this last year during the pandemic, and you see some difference in strength fatigue when using different donors. And again, look at this. If we use the spinal accessory nerve as donor, when compared to the phrenic nerve as donor, there is a statistical difference in the endurance using 1 or 2 kilograms. So why can you explain this difference in fatigue? Perhaps, I'm not sure, but perhaps brain plasticity is involved in this situation, because the phrenic nerve is designed to fire for a short time and then it stops, which is obviously the inspiration. But the spinal accessory is designed to fire all the time, to keep the head straight all the time during all the day. So that's why perhaps brain plasticity is implied in this endurance difference after a nerve transfer. And what about the famous contralateral C7? Personally, we don't use here in Buenos Aires, we don't use contralateral C7. The way an axonal input has to go all through the other hemisphere is very, very, very large. So there is a systematic review on contralateral C7 transfer, including many countries. And as you can see, the main conclusion is that most patients could not achieve independent active movement. And this is one of the important limitations after a contralateral C7. So look at this. This is a video. It's not a patient of mine. It's a patient that a physiotherapist named Subin from India sent me just to share some opinions. Look at this. He had a contralateral C7 forehand flexion, for finger flexion, right? Is this voluntary? Absolutely not. Okay, he's training, but this is not a voluntary movement. So it is very difficult in an adult brain to get voluntary control. On the other way, look at this video with this contralateral C7 operated by our common friend Mukund Tate from India again. And look how independent the affected limb is with the same surgery. And why is that? Because brain plasticity is much better, is much bigger, is much faster in children. So as William said, it is not a small brachial plexus that has to repair as a small brachial plexus. It's completely different. So let's go back to adults, and I'm finishing. Look at this. This is a spinal accessory to biceps, right? If you see, he's moving his triceps 16 months after surgery, and he's waving, he's flexing the elbow, right? So there is a strong influence of triceps contraction in elbow flexion. So we are starting now with Martin to analyze this long series of patients, and we are starting to see this difference more in deep. So look at this, 2 years after surgery. Again, the same surgery, spinal accessory to musculocutaneous, right? So when he contracts the trapezium, he moves the elbow. Although he obtained a good voluntary control of the biceps. Same surgery 2 years after. And this is much more time after the surgery, near 10 years. She was very young. She was 11 or 12 years old after the surgery. So she had more plasticity, so she got a much better control. But anyway, look at this. When she contracts the trapezium, you can see that there is still a trace of the original donor, which was the spinal accessory to the biceps, right? Look, you see that? Again, the same situation. And finally, in an OBPP, many years after surgery, again, the same surgery, brain plasticity much better. So she doesn't need, and it's very hard to see the influence of the donor in this baby. Again, spinal accessory to musculocutaneous. So as you can see, even contracting the trapezium, there is no strong elbow flexion, just moving the arm as a consequence of the trapezium contraction, right? So again, my computer is like this. It's not very plastic. It's like these windows 3.1, right? But my children, they have a much better computer, much plasticity, much faster. And my brain in the next future, probably it will look like this one. So that's all. Thank you very much. From Buenos Aires, Argentina, I want to thank your attention.
Well, thank you very much, Mariano. You can always deliver a very fascinating talk on brain plasticity.
Thank you very much.
Unfortunately, or maybe fortunately, we don't have any experience with the contralateral C7 in babies. I know that Howard, you did 1 or 2 cases with a contralateral C7. Can you present your results and your thought about these?
Well, we've only done one case in a baby where we used the contralateral C7, and the results from that so far have been actually very impressive and very good. That child is probably 4 or 5 now off the top of my head, and does seem to have independent control and can use that contralateral C7 quite effectively. So, but that's an N of 1. We also did a teenager with a motor vehicle accident type of lesion, did a cross neck C7. So that's our entire experience. So it's not enough to hang your hat on, but it's been positive so far.
And any other panelists, do you have any experience with contralateral C7 or thoughts about it? Because it's very interesting that that you mentioned this, Mariano. Do you also think that this plasticity, because when I said in the introduction that you need input to your developing brain, what about connecting C8 to C5 or to C6? Would this, of course, affect not only the output axons but also the input to the brain? What are your thoughts about this when you do this in a child or maybe in an adult?
Well, it happens the same in my experience and probably in yours, which is much bigger than mine, with this specific technique that you are speaking about. The brain, the developing brain, the baby's brain, they have 4 or 5 zones for each function. So when we grow up, we lose our supplementary control, and we fix only in one region. And that's something that's the explanation why we lose brain plasticity. So if you operate on a baby and you put a C5 into C8 at a very early moment, probably it will go very good in terms both of motor recovery and also in terms of sensory control, because they learn to the sensation, they learn correctly in the right place. So they are not accustomed to a previous sensation in another place. They learn from the beginning that to feel the hand, they feel the hand at the C5 sensory route. So that's why it's just normal for them. I don't know if you have the same experience using this technique in young babies.
Yes, we try to ask these children if they have a normal sensation, and often they say they will, but sometimes they also tell different things. So stuff that parents tell or that children tell is that sometimes these children, they can type on a keyboard, but they have to look at the left hand, and the right hand they don't have to look at it. So the sensation, so the input to the brain is diminished. This is also a question from the chat. Yeah, Thomas?
Let me ask. if those patients, it would be very interesting in those patients that you are mentioning. Maybe you could do a study about when was the surgery done indeed. For example, is it the same to do the surgery at 3 months or to do it at 6, 7, 8 months? Probably not. Maybe your results are, maybe you can find that the results are influenced by the age of the surgery. And perhaps, I'm not sure, of course, this is just a hypothesis, perhaps an early surgery would avoid that kind of mixed sensation results. I'm not sure.
Interesting.
There has been under Q&A, Hazel Brown is asking, what do you think is the best way to facilitate plasticity within the children's rehab? For example, do you think they need supplementary training, or do they just learn how to move their arm from their new innovation by themselves?
I think much of the work is done by the proper the same baby. Of course, it has to be guided by the correct physiotherapist. But in a very small baby, I mean, much of the work in rehabilitation is done by themselves, because they learn the things by themselves as we do. I mean, it's the same. As we do, I mean, as we do when we learn our language, or we do learn to walk or whatever.
Could I expand on that question? So to all of you, on the other hand, what would you think would be a supplementary way to facilitate plasticity in a baby, if not learning if the baby is not learning on himself? What are ways to foster that?
Well, what we advise the parents is to let the child play with his or her hand, and also to put the hand in the mouth so they can suck on it and they can taste it and they can sense it. Or we advise them to give the affected hand and put it into their normal hand, just to play with it. So this is one thing that we advise the parents, to get this hand into their body schedule. I don't know if this makes sense, but it's.
Willem, can I contribute? Hazel's actually, as you well know, one of our therapists, the lead therapist here in London, and it's very clear the benefits of therapy with expert therapists. We've seen this particularly markedly over the COVID crisis, where we've lost contact with people and face-to-face contact, that particularly in adult nerve transfer rehab and relearning that synkinesis, as Marianne has said, with a slightly more mature and clunky brain, the benefits to therapy are absolutely huge. And I think this is part of the problem of assessing outcomes, is we have to standardize in some way the method of reteaching that relearning, because I don't think it is straightforward. So I do agree with Marianne. I think the tiny kids, they're going to learn what they've got. But as soon as they get to walking, talking age, I think play and interaction, and somebody who really understands how to focus in, isolate and teach and learn, like teaching swimming, like teaching piano, like teaching anything, a great teacher is a huge boon and will improve outcomes undoubtedly. So I think that's a great question from Hazel.
Thank you very much for the answer. There's a question from Howard. I just wanted to still ask you, Tom, how do you actually prevent that there are not using the more deficient arm enough?
So I defer to my expert colleagues. We've got a great team and they do a great job. I think there is an awful lot of techniques on exactly body position and core control and identifying triggering movements, taking gravity in and out, using hydrotherapy. But this is a huge area of expertise. In the same way we have expertise in surgical treatment, rehabilitation is a huge area of expertise, and I think it is recognizing that that's allowing us to get better and better outcomes. So I think ask Hazel the answer to that question.
Thank you very much. Howard, you have a question.
No, this is my answer to the same question. Based on zero data, but just on observing these kids over a long period of time, for the kids who have, particularly with lower trunk reconstructions, who may have diminished function, motor function, as well as initially diminished sensation, I've never been able to appreciate that a therapy program could get them to start using that extremity for bimanual activities, to stimulate them to start doing something with it. But in those kids who then spontaneously get to the point where they've just suddenly realized they've got two hands and they can put them together, they can hold a ball or something like that, when they first come to the idea that there's another extremity there and they can use both of them, then we get a huge benefit from our therapists trying to design a program that has a lot of bimanual two-handed activities, a lot of large things, and then finer motor things to actually stimulate that once it starts. But I'm not sure I've ever kick-started that in a kid.
Okay, thank you very much, Howard, for your further evaluation and further answer to this question. I think it's time that we move on with the program. Anna, could you please start the presentation from Raymond? Raymond Say is a
As nerve surgeons, we like to look at MRC and active movement scale scores, add them all up, and see what difference we've made for a patient. But what we need to keep in mind is that ultimately, we want to produce meaningful function in a child that's growing and developing so that their outcome can be optimal when they reach maturity. We often think that nerve produces movements. However, it's important to recognize that the intervening muscle and bone can suffer aberrations as a result of the denervation. I'm going to talk about contractures and bone dysplasia, secondary reconstruction, and early musculoskeletal management to try to minimize or even prevent these. Contractures occur because of limited or lack of motion. Dysplasia occurs because bone responds to forces acting on it. When motor function is intact, according to Wolff's law, remodeling can occur. And so in this example, where there's a femur fracture and it's completely displaced, if you leave things over time and allow that motor function to produce the remodeling effect, that femur can remodel into a completely normal-looking bone. Conversely, deficits or imbalance leads to dysplasia, such as in a Charcot joint. And so dysplasias occur with neonatal brachial plexus palsies, and typically we're discussing the shoulder. That's because the stability of the shoulder joint is dependent on muscle of the rotator cuff. It's not a true ball and cup joint. There's also an existing imbalance of muscles about the shoulder. The pectoralis major, the teres major, the latissimus dorsi, and the subscapularis are all very large and powerful internal rotators that are antagonists to the infraspinatus, an external rotator. Its innervation, the suprascapular nerve, also happens to be very vulnerable to injury because as you pull down on the brachial plexus, you injure the uppermost parts of the brachial plexus. And the suprascapular nerve happens to topographically live on the upper part of the brachial plexus. So it is most frequently injured and most severely injured of all of the components of the upper trunk. Unfortunately, our outcomes of nerve reconstruction also happen to be relatively unfavorable, regardless of graft or nerve transfer. And so shoulder or glenohumeral dysplasia manifests as subluxation of the humeral head posteriorly on the glenoid, which can lead to glenoid retroversion and loss of the posterior lip and formation of a pseudoglenoid. Fortunately, as opposed to outcomes of nerve reconstruction, outcomes of secondary reconstruction tend to be very reliable. This patient has a shoulder internal rotation contracture and manifests with deficits getting his hand to his mouth. He uses his other hand, and getting his hand to his head. You just can't get it up and back. So we start with a shoulder release. This is the anterior view. The patient's facing us. Legs are on one side, the face is on the other. And we've gone through the deltopectoral interval to identify the coracoid process. You can see the origin of the biceps tendon, the insertion of the pectoralis minor, as well as the pectoralis major insertion onto the humeral shaft. We can perform a fractional lengthening of the pectoralis major by making multiple partial thickness perforations in the tendon so that it can elongate. And then we go to the coracohumeral ligament and divide it so that the humeral head can shift anteriorly as the shoulder joint rotates into external rotation. We now switch to a posterior approach, so the patient's facing away from us. This is through the axillary crease, where we can see the latissimus dorsi and teres major conjoined tendon as it inserts onto the humeral shaft. The axillary nerve dives underneath that tendon on one side. The radial nerve makes its way over top that tendon and then dives into the triceps interval from there. With that tendon released, we can see the thoracodorsal nerve as well as the course of the axillary nerve. And we transpose that tendon through the interval between deltoid and triceps onto the greater tuberosity of the humeral head. Again, this is the posterior view with the site of insertion through the interval between triceps and deltoid and onto the rotator cuff. We can see the axillary nerve as it branches off and innervates the deltoid muscle. This is the tendon sutured into place. And this is the child after surgery. It's easy to get hand behind head. And you can easily get hand to mouth. We looked at outcomes of shoulder release and tendon transfer, and as expected, we found that there were benefits in overall active movement scale scores, malaise scale scores, and patient-rated brachial plexus outcome measure scores. We also found that there were some losses, and those losses were in internal rotation. About 10% of children were unable to reach their belly after surgery. If you look at the diagram on the right, that's the arc of motion with the shoulder and abduction, and you can see that rather than increasing motion, we've actually more or less shifted that arc of motion. And so some folks will present photographs like this after musculoskeletal reconstruction where a child is fully externally rotated, but knowing that there are deficits that come with this, this child is unlikely to be able to come back in and get to midline. And so when we do these procedures, what we're trying to achieve is maximal external rotation when the shoulders are in an abducted position, but preserving internal rotation when the shoulders are adducted. And we're trying to avoid this situation on the bottom where we've got full external rotation in the adducted position, which is not a meaningful function and not a meaningful motion. What that study also tells us is that motion achieved through nerve surgery is probably superior to balance achieved via secondary surgery, given that there's gains and losses and shift in the arc of motion. And so for this child here who's achieved almost full external rotation and abduction through nerve reconstruction, I think that this is a more ideal scenario where if we still don't have the abduction and external rotation that we want, we still have our internal rotators that we can use to rebalance and further fine-tune this shoulder. The other option for shoulder rotation is a humerus osteotomy, and I think of this as a salvage. You're bypassing the shoulder joint and you're just changing the position of the arm. And so This is reserved for situations where there is severe glenohumeral dysplasia and we don't think that we're going to maintain an arc of motion or rotation of the shoulder following any kind of tendon procedure. It's also useful in unfavorable scenarios, and this is something I've run across. A patient with an extended Erb's palsy treated elsewhere who underwent Oberlin transfer and spinal accessory to suprascapular nerve transfer without addressing the other deficits. With a persistent lack of abduction and external rotation, there was now no latissimus dorsi muscle to transfer, and there was no trapezius muscle because it had been sacrificed with the previous nerve transfer. And so humeral osteotomy, I think, is really the only option in this child. In terms of elbow flexion, there's options for what we call Steinler flexorplasty, where the origin of the forearm flexor pronator group is moved proximally up the humerus so that there's a greater elbow flexion moment. That simply augments the flexion that's there and can't be used when there really is no elbow flexion at all. An alternate is a bipolar latissimus dorsi muscle transfer, but I don't like this because it sacrifices a muscle that is a workhorse for rebalancing the shoulder. So my preferred method in situations where there is no elbow flexion following primary reconstruction is for a free gracilis muscle transfer. This can be innervated by the intercostal nerves, and in the photo on the lower left you can see the lateral thoracic vessels, which can be used for microsurgical anastomosis to provide perfusion for the transferred muscle. Do the hand to nose. Okay. And with the other side. Hand to ear. Okay. Hand to the back of your head. Okay, great. And I'll have you
Anna, the movie stop?
For forearm rotation, there's an option of radioulnar osteotomy. However, the pronated position of the hand typically is more functional than supination, so we don't use this very often. In terms of wrist extension, we're in an exciting world where we're talking about options for nerve transfer to achieve wrist extension. And my advice is to beware that the pronator teres and brachioradialis tend to be workhorses for tendon transfer when wrist extension is absent. So important not to burn those options if contemplating nerve transfers. For the hand, it's uncommon that we do secondary tendon transfers, and these are highly individualized for individual patients. Can we prevent glenohumeral dysplasia, and does it occur in young babies? We looked at this question when we examined all of our children undergoing nerve reconstruction who had indications for surgery according to the Toronto protocol. We used the Waters classification, which grades shoulder morphology from 1 to 7. And interestingly enough, 74% of children had significant glenohumeral dysplasia. It was less severe with the more severe palsy type, as indicated by Nareka's classification and number of root avulsions. And we found that kids who were over 6 months of age at the time of surgery all had dysplasias, whereas younger kids, 50% of them had dysplasia, and this was related to recovery of internal rotation, pectoralis major muscle mass, and active abduction. So to avoid all of this, I think it's key that kids have a good therapy program of passive range of motion and stretching. As clinicians, we need to be suspicious of deep and high axillary folds and additional creases in the upper arm. And if that's the case, we need to screen with ultrasound. We do this routinely every 3 months, and you can see the posterior subluxation of the humeral head. With significant subluxation, we'll use botulinum toxin to temporarily denervate the internal rotators so that there's greater balance, and we'll use spica casting in order to position the shoulder into external rotation. There are options of early positioning, maintaining the shoulder in external rotation when children sleep. And after nerve reconstruction, I think it's useful to use a shoulder spica to position the shoulder into external rotation rather than using a cuff and collar sling that locks the shoulder into internal rotation and can aggravate the problem. So even if our nerve surgery could produce something akin to an F1 race car engine, if glenohumeral dysplasia is present, this car is not going to move anywhere. So I think this is a key slide because it's important to recognize between nerve and movement, there's muscle and bone that need to be maintained and kept in good health if our nerve surgery is to do anything. Thank you. In summary, dysplasia in infants occurs frequently and early. There are multiple strategies to try to prevent it. Secondary shoulder surgery is reliable, but it's a rebalancing procedure that doesn't produce a lot of additional significant movement. Primary reinnervation is key to producing optimal outcomes and providing the opportunity for secondary reconstruction to augment what's already been achieved. Thank you.
Okay, I think this was a very interesting presentation, especially for us primarily engaged in nerve surgery. It gave us a good overview of the bones and joints that we have to take into account too. Of course, Raymond is not here, unfortunately, to answer any questions. So unless there are any of the panelists who would like to share some of their experience and add something to this presentation, I think that we will move on to Tom Quick. And after Toronto and Ann Arbor and Argentina, we move a little bit closer to home, a little bit closer to Europe, but
Don't tease us. We still love
Not Europe.
So Tom, please provide us with your vision from London.
Thank you, Willem. Yeah, after our Brexit disaster, I'll just keep quiet about the European thing for now. Yeah, so it's very kind of you all to invite me after the many years of experience that we've heard from. I speak, as Linda mentioned, 10 years now here in London, but still as a newer member of the community. From our big metropolis with a very large population referring in, I want to talk a bit across everything that we've heard from all the experts that have commented on the individual. I'm going to try and bring things together just to how the way that we look at things. I'm going to produce more questions than answers intentionally to avoid too much controversy. This wonderful picture by William Hunter here in the British Museum, the British Library, sorry, starts our story for all of these macrosomic children and shoulder dystocia. And I think we have to give at least a quick mention to the processes of prevention. We know that we can never make these children normal who have permanent injury, and avoiding the injury, I think, is part of our job as well. Injury to the brachial plexus is, of course, incredibly interesting and exciting, as we've mentioned, very, very different in the children than it is in the adults. And it affects the whole arm. Majority, as we've said, the upper trunk, the suprascapular nerve, the axillary nerve affecting the shoulder, but also affects on the elbow, forearm, and occasionally also the hand. But all of it affects function. As we function by positioning our hand in space, all of these, the glenohumeral joint, the scapulothoracic joint, the elbow, and the forearm, all they do is place our hand in space. If they are not working, then we will struggle. And at the end of it, it's children and it's families, and function is the key thing, as we have mentioned. So the baby is boss. How bad is the birth-related plexus? We've heard from experts how we might consider classifying it. Willem's done some great work on the direct relationship between birth weight and the severity of the injury. Mechanisms of injury, I think, are also particularly pertinent. Traveling around, seeing other people's practices, we're seeing different injury patterns in different parts of the world. And I think this relates regional obstetric teaching. And also more recently with work in the island of Ireland, I've seen that the collapse of their tiger finance economy led to problems with healthcare and problems with practice and staffing and training that led to poorer outcomes. We've all talked about the time to recovery. It is a surrogate for recovery, but you can have a slow conduction block recovery of a group 4 that completely resolves, or obviously an avulsion injury which won't recover at all. And so time to attain certain scores is certainly a way to classify, but it isn't the whole story. And what exactly is the injury? Somewhere between the stretch and the neuroma in continuity that needs excision and grafting and avulsion injuries, there is a mixture between all of these. We don't see, as in the adults, pure avulsions as commonly, and we don't see pure ruptures as commonly. As Willem was stating, we have a neuroma in continuity or a stretch injury subneuroma in continuity that is our lesion of presentation. And the interaction with the growing brain, and an injury at this time of a very vulnerable brain, as Thomas Colstead published, there is a great deal of morbidity that can be incurred by secondary injuries to nerves that perhaps are lesions in continuity or neuroapraxic or conduction injuries by creating new axonopathy. So intervention is not without risk to the supercomputer that we've been told about. So how are we to classify it? Narrowcast we all use, and this classification of upper trunk, extended, so upper and middle, the whole plexus and the whole plexus with a Horner's are all surrogates. In fact, the actual Narrowcast classification was shoulder and elbow, wrist, hand and eye, and we've taken that to be directly relating to the amount of nerve roots. Avulsions, as we've heard, we do see more and more when we look for them, subtotal degrees of the avulsion injury, injuries that can actually recover without intervention to some degree. The concept of a conduction block, not just being a single event, but being persistent with scar. So hypoxia, squash, injury, not resolving or having a chance to resolve until the situation is improved around them. A concept which we all hold to in adult practice and seems to be slightly alien in pediatric practice. Then the concept of a neuroma creating axonal confusion. So axons going to the wrong place, an unintended nerve transfer. So muscles being controlled by nerves that should have gone somewhere else, occasionally an antagonist cortical control. And then the secondary injuries. We've mentioned this wonderful developing organ, the pinnacle of human change and evolution is this brain and the way it can grow after birth and develop. Injury to it at that time is hugely important. The child does not develop the same schema of a limb when it doesn't have the feedback, the movement, the taste, and the function from the limb. But not just that, they don't crawl, they don't develop reciprocating gait patterns, they don't develop core body control and have changed balance. So how do we assess the birth-related plexus injury? Well, it's with repeated clinical examination, absolutely, looking at active and passive range of movements, looking for the Horner's sign. But we do rely here heavily on neurophysiology. Thoroughly accept all Linda and Howard have said. I don't think a test can be overly optimistic or under optimistic. It's data, it's how you apply that. And as a facet of examination, I think it is key because it provides extra information. Is there, as we've said, a muscle that is clearly having motor units but not moving? Well, why should that be? Is it cortical control? Is it co-contraction? Or is it a problem with firing, fatigue, or control? All of these are extra pieces of the puzzle, and I think it is remiss not to think of the whole musculoskeletal system in the assessment. passive contractures of joints, as we've mentioned, are absolutely key. And we try and balance neurophysiology, clinical examination, and a assessment of the shoulder, as I'm sure we all do. Imaging, as we've mentioned, again, can add more information if a specific question is asked and we believe that we have a sensitive and specific test. The operation itself as an exploration and a data collection exercise is really key, but we do have to think of both the afferent and the efferent function. An awful lot of these contractures, particularly around the shoulder, as I'll mention, I think are related to an injury to the majority. Even in a pure motor nerve, we have a majority of fibers that are bringing information back. Muscle is a proprioceptive organ. And when that's changed and the muscle is placed under stretch by growth, muscles do, stupid muscles, nerve injured muscles do what they can do, which is contract. Whereas normal muscles would quite happily say, well, that's skeletal growth. It isn't a muscle being stretched and I need to contract against that. It's a natural process. And so we get these contractures. The key thing though, if we can't measure, we can't classify. And if we can't classify or measure, we can't compare and we won't learn. And I applaud the work that's been done under Willem's tutelage and leadership of identifying what we all think we should be assessing and collecting. Without this, we will not learn. We can do a variety of exciting nerve, muscle, tendon, joint procedures, but unless we know how to measure the outcomes of those and standardize how we do them, we're going to struggle to say what's useful. So we have to work across specialty and across countries for large data collection. And there's that suprascapular nerve. And we see it time and time again, kinked, controlled, tethered down within scar, non-stimulatory. After a neurolysis, and Howard, I'm not going to go far enough to say that I think neurolysis is definitely a treatment, but in case after case, I've seen nerves that have a persistent conduction block as evidenced intraoperatively with non-functional above function beyond the lesion, and then a conduction being shown across them. Now, again, I don't know when that's enough. I don't know when it feels not quite right and we have some twitch from a stimulation above a lesion, but I do know that neurolysis is definitely improving the function of a nerve in an intraoperative assessment. How we balance that and how we make those decisions, again, it's learning how to use the data that we've got. And the same for the anterior and the posterior divisions. All of that upper trunk is really key to getting information passing as smoothly as possible from the afferent and the efferent directions. And we know that the standard child, as we all have pictures, has a variety of presentations at different times. But there is this problem of the shoulder. The involvement, as we've said, the more severe involvement of the higher roots, the lesser of the middle and lower roots, producing an imbalance in torque. A loss of active external rotation and injured muscles internally rotating powerfully and contracting, particularly in the nerve injured portions, the upper quadrant, the upper anterior quadrant of the subscapularis, the rotator interval, and the soft tissues within that area, creating contracture. And as we've heard, contracture leads to a problem. And there may be active external rotation to a locked passive range, or there may be no active external rotation, but they're two different conditions and can't be treated the same. So some kids can externally rotate here just fine, because this is the inferior part that's being stretched. The superior part in adduction comes across and they tend to bring the arm out and trumpet. This leads to skeletal dysplasia and imbalance, and we get this abduction contracture of the scapulothoracic joint, and that's a real problem for treatment. Again, we've all got the same pictures and we can understand the problem. This is easily recognizable. This is a locked passive external rotation. It is very different from a shoulder that's going this direction, and we should never see these pictures because we should be able to identify that prior to it getting to that stage. And even more, we should identify it because when it's become fully dislocated like this with a huge smeared glenoid and a dysplastic humeral head. But again, it's not just putting a humeral head into a joint and creating a joint. It's understanding the bone torsion. So the humerus has a standard retroversion of around 20 to 30 degrees. This can be hugely increased and exaggerated in this condition because of the imbalance. And then to get the humeral head onto a glenoid to try and form it, you have to externally rotate huge amounts. This is when a treatment which is not a salvage, but a restoration of normal or a derotation humeral osteotomy can help, because you can return it to normal retroversion, meaning that you've then got a humeral head that will sit against the glenoid and develop it without having to put the arm in a ridiculously non-anatomic position to do that. So it's recognizing the bony anatomy, particularly torsion, that's hard to comprehend, but easy to see intraoperatively, soft tissue tension and muscular function. Do all of those and the nerves have got a chance, because you've got a joint that will work. Then there's the co-contraction that we mentioned of. We see it time and time again. It is treatable with physical therapy, retraining, and also with botulinum treatment. And we see persistent evidence of loss of the co-contraction. You can see flexors and extensor activation here in the top, relatively normal, in the middle one, very high co-contraction rates. This again can be a reason why the elbow won't flex at 2 or 3 months, because the triceps won't let the biceps, because they're both firing at the same time. So the co-contraction can happen around the shoulder as well, with abduction, with the lat and the pec co-contracting against the deltoid and the supraspin. But because the C5 injury is the worst, the shoulder gets the worst impact of that nerve injury. The imbalance is felt. We know that we can treat this. We know that through stretching, we can improve it. We know that through a gentle release and a controlled release, we can try and affect the balance to try and improve that. And glenoplasty, the salvage, as I see it, of trying to create a glenoid, is something that we should never get to. My surgical pearl, shoulder surgery is absolutely key and works, but we're still not sure when and where. It is an incredibly effective procedure if you appreciate nerve injury, muscular, soft tissue, and muscle function. We don't want to delay, but obviously we don't want to treat people who aren't going to get better. Just very briefly, as we've mentioned, the brain injuries, balance, coordination, body image, psychology, these are all secondary effects from the primary PNS injury that leads to adult and later life dysfunction. And so prognosis comes from function, of course it does. So looking mainly at the shoulder and the elbow and the forearm, but also elements of pain, problems when people transition from roles in childhood, in adolescence, to adult life, to work, to being parents themselves, and the problems of body image. It's complex, and this manner of appreciating work, the complexities, has come through working together. And I don't think we get anywhere without recognizing the expertise in therapy, in neurosurgery, in orthopedics, in plastics. And I thank Hazel Brown for her work in our unit in widening our appreciation of exactly how we can improve things. And I thank the whole rest of the team here in London. Brachial plexus injuries are complicated. We've known that for a long while, but teamwork is absolutely necessary to deliver the best clinical care and drive research and audit. We need data, and we need to compare data. I love this phrase, but there is no expertise in isolation. You can't do it by yourself. Shoulder pathology is complex, but important, and it's potentially progressive, and we're not sure in whom it is truly progressive, but prompt treatment is important for good outcomes. And just once again, how are we going to learn what's better? Contralateral C7 may look great on a video, but the patient may not be able to go to work and enjoy their life. Thank you very much.
Thank you, Tom, for this very elaborate presentation. And also thank you very much for putting the emphasis back to the shoulder joint, where Raymond already put it, and to conclude that apart from repairing the nerves and the control of the brain, the shoulder joint may be the most important one to define function, especially in these upper type brachial plexus injuries. I was we've had some debates about neurolysis and whether this is a treatment or not, and I think there are some cases where there is a really constrictive neuroma around the nerve, and then you when you cut this away around the nerve, then you see some recoloration of the nerve. But it's very difficult in other instances to think what neurolysis may do. And Howard, you probably also have your meaning of neurolysis, because you investigated this in the beginning of your experience. Could you elaborate on that?
Well, the data that we collected was really very clear. So neurolysis, for example, of a neuroma in continuity, where you see a massive scar, shows increased outcome, shows improvement, statistical improvement at 1 year out following an operation. But that difference disappears over time. And by 4 years out following operation, it's either modest or totally gone. So we cannot improve statistical movement on AMS scores, and we cannot improve function by doing neurolysis of a neuroma in continuity. Our data doesn't support that.
Howard, how can you explain that drop off? If there's an improvement in neurologic function that isn't being maintained, how do you explain the pathophysiology of that reduction?
Well, I would assume, I can't prove this obviously because we don't take the patients apart, but I think what's happening is you do get some reinnervation, having neuralized some component of the plexus, but it's very modest. And so those antagonist muscles that were winning before can once again win again. So you don't get enough reinnervation. You don't get a powerful enough reinnervation to produce a lasting effect. That would be my answer.
Yeah, but we know quantifying reinnervation is not something that actually helps with force, for example, peak force. And we've shown that peak force is not related to satisfaction of outcome. So I think we are seeing that there is more to recovery and more to gaining what we've got from the nerves than purely nerve surgery in isolation, which is what you powerfully looked at. I think the groups were slightly inequitous, and I think standardization of any surgical procedure is a challenge. But I do think that we're seeing what we all accept as a neuroma in continuity. Now, I don't have the data, so I'm playing devil's advocate here, but I've seen anecdotal things, and I have a belief that I will try and challenge constantly, which is why I've framed it as such. There is no proof in this, but I do believe that there is, in the adult's nerve injury, we see this time and time again, an environment in which the axons that are present cannot function. And I don't see why that cannot be part of a neuroma in continuity treatment.
So I would simply take you back to the title of this whole webinar, which is that the babies aren't the same as adults. So I'm not pretending to have any idea what happens in adults with brachial plexus lesions, but I know in the little babies, those neuromata are not contributing usefully to their long-term function. So if it's not contributing in a positive way, why not attempt to get something better?
But we do know that creating axonopathic lesions, excising neuroma in continuity where there are axons in continuity, we all accept that, is a injury to a vulnerable developing child. So we know that they're more vulnerable. And we also know kids develop better and have greater plasticity. So I would say all of the arguments for pediatrics is we can do more with what we've got rather than trying to injure again.
Well, you see, again, we can argue this up and down and sideways, but I stand by the data, and the data is robust, and it's over many years and over many patients. The counter argument to what you've just described, of course, is that if you want good axonal sprouting, and if you want good regeneration of nerve, isn't the best place to start in a nerve or a nerve root that's produced a vigorous, large neuroma, showing that it wants to and is capable of regeneration? Isn't that the best environment to cut a nerve and repair it in these little babies? Because clearly something's going to happen.
Well, I'd say it's best to take those axons that are there and haven't died and are there but not functioning and allow those to function. But I agree, there is no data here. It is theoretical. So I'd like to see your data from your patients. Yep. No, absolutely. It will come. It will come. But the problem is, as I've said, we'd have no method of assessing how to compare. And so this is the big problem that we've all had, is how do we count? How do we say how bad is this lesion? We have to and I do think we all see different lesions. Seeing Willem's work, work in Ireland, work in other parts of the world, there's a different lesion that we see here in London than is in Leiden or in Dublin. So I do think we're not all comparing the same, and maybe rates of avulsion, if we could standardize even something as simple as that, might show us that we're not all seeing the same injury. Maybe we've never seen the same injury twice. Maybe it's that complicated.
This is a very interesting discussion. I wanted to ask you one question about the neurolysis. If you do the neurolysis, do you see the improvement directly after surgery? So this is a constriction of the nerve, or is it that you see a gradual improvement after some weeks or some months? Is it axonal regeneration that you get in another way, or is it improving conduction?
So again, I think we treat a huge spectrum of problems, and I think I see a variety of outcomes. I do see somewhere I do primary nerve surgery and limit it to a neurolysis, and there was an improvement seen at week 2 when I'm checking a wound, but there's definitely improvement later. I see somewhere, just like an adult, you do a neurolysis and it takes 3-4 months to improve. I do somewhere I do nothing, and as you've mentioned, you put the plexus back in, so you put the shoulder back in and everything is better. I think there is a huge variation, and I think exactly what is improvement isn't measured short term. As Howard's said, I don't think a month or so outcome is really important. It's adult function that we're aiming at. And fatigue and pain and body image and all of these things. We can't just do an MRC grade or the ability, to control and coordinate movement. It is very, very complicated to assess what is better. There is no easy what is better outcome. So in answer, yes, I've seen them get better very quickly, and I've seen them get better slowly, but that's the natural history, that things get better slowly.
Okay, thanks.
I'd have 2 different questions. And the first is referring to co-contracture, because we heard mentioning co-contracture in 3 presentations. So what would you do if you'd find after surgery you'd find reinnervation but co-contracture? What are your steps to treat that?
Is that a question for me?
To the whole plenum.
You can kick off, Tom, if you want.
Okay.
Well, I don't really do obstetric brachial plexus surgery. So of course the one term that is floating around is Botox injection to weaken one of the muscles, and at least that is something that is done or attempted in adults sometimes. So I'd like to hear from you if you would do that, and if, how would you go about it?
So co-contraction's not pathologic. We can have physiologic co-contraction. We all do it. When you're learning piano, you stabilize the other joints. When you're carrying a tray of drinks on a train, you co-contract to stabilize and simplify a motor process. So we see it physiologically. We also see it pathologically if you can't exert a movement with an effector and the antagonist is working against you. That's often not just for reasons of sprouting, but it's for reasons if you have a muscle that doesn't have an afferent supply, the brain will try and grab an afferent information from the movement of that joint from the antagonist and increase their basal tone and their contraction. And we know this happens in fatigue, in runners and sportsmen, that when they get tired, the muscles start to co-contract more to stabilize joints and to give more information. So it isn't always pathologic. It changes constantly. The state and degree of co-contraction changes, but it can be rehabilitated. You can grow out of it. Kids do it as a normal motor pattern that they then grow out of. Physiotherapy can help, and we see synkinesis and co-contraction all the time. We do it in nerve transfers, we do it in nerve grafting. We always see this. It's not that abnormal. But yes, we can use botulinum toxin. It isn't just that. There is evidence that certainly that it isn't just the paralysis of the antagonist, but that it's transported centrally to the Renshaw cell that stimulates and coordinates antagonistic control and modulates the Renshaw cell function in the spinal cord. So it is a complex treatment, but it definitely lasts longer than the paralysis of the antagonist.
So that is something that you could and would use also in a child.
Absolutely,
Yes.
yeah.
And there is I don't know if there's good data on it, but especially for the biceps triceps co-contractures, it works perfectly, and the child will learn. I think that Howard showed that if you do use Botox in the shoulder, it only has a temporary effect and no effect on final function.
Okay, thank you very much. Maybe if I'm allowed another question, because we have audience from several countries. So when and how do you actually see the kids first? I know from Martijn, from the Dutch experience, that you actually, at least that was my impression, you actually almost get called at the time of delivery when there is the danger of brachial plexus palsy, and I just assume it's not the same in every country. So when do you actually see the patients?
No, we don't get called before they have a name, but we get called quite early. So we often see these kids when they are 4 to 6 weeks old. But this really took some time. So we had to announce it again and again to the pediatric neurologist and to the general pediatricians that we wanted to see them early, also to be able to follow them up and to compare. But we see them at 4 to 6 weeks.
Because it's frequently the parents and sometimes even physiotherapy therapists that are afraid of surgeons.
No, they're not afraid.
And the others, when do you see the kids for the first time, usually?
You mean before the pandemic or after?
Once again?
Before the pandemic or after?
Before.
Okay. No, we the same experience. We've been doing a long work trying to spread this surgery, so the patients are coming earlier each time. But we are still far away from the situation that happens in Holland.
So internally, at least in Ann Arbor, we get called by our own hospital, while they're still in the hospital, mother and baby. Externally, it varies, just depends on, whether it's a physiotherapist versus a pediatrician versus an obstetrician even. They're not afraid of us anymore. And I took lessons from Martijn and Willem again, came back and took the dog and pony show on the road. So over the years, the time lapse from birth has decreased substantially, so that for most of our new babies, we're getting them before 4 weeks now.
And Howard?
We see them as soon as we possibly can. Again, as Linda just said, if you make people aware that there's a brachial plexus clinic or whatever you want to call it, they're actually thrilled to be able to send them along because they don't know what to do, and they're happy to let somebody else look after this. So, and we're very lucky. We can have our physiotherapist see the baby before I even get a chance to visit with them. And so we try to do that within 7 to 10 days of getting the referral. So we usually can see many of these kids in the first month of life. So we try to see them as soon as we possibly can, again, to gather as much data as we can over time. So the milder lesions I may not see till they're 3 months old, but they will have been seen once or twice by the therapist even before that.
Good evening, everybody from Valencia. I just want to congratulate you, everybody, for your outstanding presentations and webinars and excellent content of the webinar. And just want to thank Willem and all of you for organization of this webinar, which is in continuation webinars of peripheral neurosurgery section of ENS, and Thomas for leading this. My question is, would you and in which situation would you operate children with late admission 12 to 18 months after the burn, so the birth? So not 3 months, not 6 months, not 9 months, but admission 12 or to 18 months after delivery with obstetric brachial plexus palsy.
Yeah, this is a very, very difficult question to answer. And I think that you have to discern also whether this is an upper brachial plexus lesion. And sometimes these children come in so bad with a shoulder that's so bad after 1.5 years that you can repair the nerves, whatever you want, but the shoulder is the limiting factor. So then you have to treat the shoulder first. But if there's a child who has no hand function at all, comes with you at 18 months, then I think you should try this. The most difficult one is where the child has some hand function after 18 months and you don't know, and you know that you have to start from scratch again if you want to reconstruct this. But luckily these children are rare in our hands. Howard, you raise your hand?
Sure. So we don't have happily, this doesn't happen often. We're lucky that way. So we don't have a hard and fast rule for this, but by and large, if they're coming after a year of age, our general thinking tends to shift towards secondary reconstruction in a musculoskeletal way. But also the first thing we'll think about is, are there any nerve transfers that can be done usefully? Because there is some pretty good data coming from Mohammed Al-Katan and others showing nerve transfers may still be effective in these babies up to 2 years of age and perhaps even a little beyond that. So do you have a nerve transfer that will be useful for this child rather than doing a full-on plexus reconstruction?
So I'm going to go on what Howard said. I agree with that entirely. The only thing I would add to that is perhaps this is another circumstance where EDX might be useful, because our neurologist insists, and I've seen it too, that a quick needling will tell you the status of the muscle and whether or not it's even in decent shape to take a nerve reconstruction. Otherwise, it becomes a secondary reconstruction for us as well.
There is another question from the auditorium to the whole panel from Dr. Tatarchuk Mikhailo. He's asking for the main message to the obstetrician.
First, be careful. And second, don't promise the parents that it will be all right, because sometimes it doesn't.
My main message to the obstetrician is talk to the family. The ones that the obstetrician spoke to are less likely to litigate in those countries that are litigation. It's not how severe the plexus is. It's not anything like that. The people that litigate are the ones where the obstetrician disappeared under the carpet, never talked to the family and said, I'm sorry this happened to your kid. So my main message is tell the obstetricians, talk to the family.
Tom?
I would just say an appreciation of prevention. Shoulder dystocia is a disproportionate shoulder of the child width to the pelvic outlet. You cannot overcome that by pulling harder. There are maneuvers, obstetric maneuvers, that can be performed with good training, so-called McRoberts within this country, but deep hip flexion to try and increase the effective diameter of the pelvis. So not to pull the child out, but to try and improve that ratio of distances so that the injuries are not created or are less severe.
Anything additional from Howard or Mariano?
Okay, great. So I think it's time to sum up. And we've heard these speakers naming all these unique features of brachial plexus birth injury and how we have to adapt our treatment to these instances. And I think that most of them, they second that the treatment of brachial plexus birth injury is teamwork, and that we have to do this together with all different kind of colleagues. So I want to thank everybody for your attention and to take part in this webinar, especially our presenters from all over the world, from Argentina and Toronto, USA, London. I want to thank you very much, and I hope that we can meet in person very soon again. Thank you so much.
Special thanks to the ENS for giving us continuous support for online this webinar, even from here, from Valencia, because all team of ENS is here in Valencia, organizing TC course, spine educational TC course, and Anna Rek is also here. I waved from her screen on the beginning of the webinar, so this is teamwork also.
Thank you so much, Lucas. Thank you for your words.
Thank you for this addition, Lucas. And I want to point everybody that if you want to see this webinar again, it will be put on the ENS website, and you can also forward this to your colleagues who couldn't make it to the webinar. Thank you very much.
And the next edition of ENS peripheral surgery section webinars will be on December 16th by Shimon Rokin, the experimental research. So to all participants, you are more than welcome, and thank you.
Thank you.